honest questions with honest answers. This is Unfiltered, brought to you by the Emergency Medical Minute. Welcome back to Unfiltered. This is your host, Nick Sippis. Happy 2020. We are excited to announce a new collaboration that we're going to be doing a lot with this year. There's an exceptional group of podcasters with a lot of overlap with our cohort over at Carolinas Medical Center in Charlotte, North Carolina. The name of their podcast is EM Guidewire. There's great clinical content. There's great extra clinical content on there. They have great faculty and residents who are actively involved in a number of interesting projects, and we're going to be collaborating with them a lot. We're going to be doing some collaborative work with them, with speakers, and lot to look forward to. So keep that on your radar. And as part of that, our first collaboration is with one of their outstanding distinguished faculty members. So Dr. Vivek Tayal is a pioneer in our field of emergency medicine. He has had a long, distinguished career. I can see why he was picked by the powers that be on their end and as well as on our end to be our first distinguished guest. He's been instrumental in the creation of ultrasound as such a vital, integral part of our field. And he's got fascinating perspective on the kind of a longitudinal look at how ultrasound has developed over the course of the last 20, 30 years, and how he's been instrumental in that. And so without any further ado, I'd like to welcome onto the podcast Dr. Vivek Tayal. Welcome, and thank you for being here.
Well, thank you, Nick and Nate. And, it's an honor to be here and look forward to telling your listeners about, some of the things that have happened to me, but it's a great honor to be here.
So we've had a great time getting to know each other over the last couple of hours here in the studio. Dr. Tayal is coming to us from a homemade recording studio in Charlotte. He's been exceptionally patient with us as we figure out how to make sure that his sound comes through, and we appreciate his time. And then over the course of the time that we've had, he has shared some insight into his story. So if you wouldn't mind kind of sharing with us kind of where you've come from, how you got into this in the first place, and some of the very interesting parts of what ultrasound looked like back in the day when it really hadn't even started to exist yet.
Thank you, Nick. Well, just to introduce myself, I'm a native of the D.C. area, born in Washington in the JFK era, and grew up in Northern Virginia. It's a great place to grow up, and had a wonderful schooling. Eventually went to the University of Virginia for undergrad, but then I think I picked medicine because I was interested in science and wanted to work with people, and I think it just sort of fit what I think I wanted to do in terms of career. Though I wasn't naturally attracted to medicine, like I always wanted to be a doctor type thing. But got accepted at the Medical College of Virginia in Richmond in the 1980s and had very great clinical experience. Joe Ornato was a mentor in the Department of Emergency Medicine. He's still there, actually. One interesting thing about my experience at MCV was we, as a third year, the AIDS epidemic had started. And we started to get patients who had AIDS, and we really didn't know, the whole situation. I mean, there weren't antivirals and things like that. All these patients had immunocompromising diseases, and a lot of people were scared. I drew all the blood on my patients with AIDS by myself because the nurses were concerned. So it was an interesting time. I saw the fear of my patients then, and it really touched me. So anyway, it was a developing, time for me as a physician. Went in, thought emergency medicine. How did I get into emergency medicine? I happened to be doing a community practice rotation, my second rotation in third year, on the Eastern Shore of Virginia in a hospital called Nassawadox, and it was a small hospital, very rural, but it was the only hospital for the Eastern Shore of Virginia, and we had a lot of sick patients. But there was a tight bond between the physicians there and the community, and I was really touched by that. at night, I really didn't have anything to do because we stayed at the hospital. So came down to the emergency room and volunteered to see if I could do anything to help the physicians there at night, and started to learn about emergency medicine. I was like, I think this is what I want to do. And it sort of attracted me, that the pace and the type of patients they were seeing. They let me sew, they let me do other stuff. So I was like, okay, I think I know what I want to go into. So eventually there were no EM rotations, at least in third year there, and then fourth year I did a rotation. Matched at Charlotte Memorial, which then became Carolinas Medical Center in 1980s, and had a great faculty, Doctors Baker, Schaefer-Meyer, Runge, Ford, Martinez. A lot of them you may know as from national positions like Dr. Schaefer-Meyer, Asep. Dr. Runge went on to be the head of NHTSA and Homeland Security medically, and then Dr. Ford, toxicology. A mentor of mine was Bob Schneider, who really taught me to be a assertive, aggressive physician, as well as Dr. Ford. Rotations were great. And one thing I just comment on for all the residents out there, like our rotations in the 1980s, sometimes they didn't really fit exactly. They were longer than, like I had a plastic surgery rotation for 6 weeks, but I got to do a lot on plastic surgery that had nothing to do with plastic surgery. So I really learned a lot, from my attendings and the staff on those rotations. Two episodes that sort of pushed me into what eventually would be an ultrasound career, or two incidents that I can remember for your listeners, were on the late third year. I had a middle-aged male with back pain who was hypotensive, who came into one of our resuscitation bays. And after we were concerned about aortic aneurysm, we consulted general surgery and vascular surgery, and they continued to have a prolonged discussion, which eventually led to sending the patient for a CT. CT scans took 45 minutes back then.
We had to get someone to jump on the bicycle and start start pedaling the bicycle.
Exactly, we needed to power it up. Exactly.
Running the hamster wheel, yeah, I got it.
And so the patient went up there, and as you probably could figure out, the outcome was not what we wanted. The patient succumbed, and I had to tell the family, and I was really pretty distraught about that. The other things were like when we had ruptured ectopic patients, or patients ruled out ectopic, we had to do choledocentesis sometimes, and it's brutal, just brutal, not a good thing. So, and not a great test. So I knew there was got to be a better way. Went into the Air Force as I had a scholarship, and got selected to go to Wilford Hall Medical Center, and there were two new faculty members, Dr. Mike Girardi, who went on to be ASAP president, and myself, and Dr. Dalsey, who was the chair at the time, said to each of us, need you guys to take on some responsibilities. And Dr. Girardi took on the liaison to internal medicine, and I took on ultrasound. And, that's how I got into ultrasound. Dr. Dalsey offered it, and I took it. So at that point, I sort of started to take courses around the country and make an effort to get an ultrasound machine at our emergency department at Wilford Hall. It took me all 4 years, but we finally got Ultramark ATL4, Ultramark 4, and there was one with a mechanical probe. So, even back then, the technology was maybe primitive, but did a great job. And we started to use ultrasound towards the end of my career in the Air Force. I got to do a lot of things, got to be a research director, assistant chair, and learned a lot in the Air Force, got great experiences, did some really cool stuff, and I have nothing but praise for the United States Air Force and my experience. Finally, thought I was probably going to return out to civilian life, and returned to CMC. The department had changed. Dr. John Marks, who you've talked about in other prior podcasts, was the chair then, and he was a fantastic chair. A lot of new faculty: Chris Tomaszewski, Mark Kirk, Tom Blackwell, Russ Kearns, Jeff Klein. So we had a lot of, in addition to all the older faculty I knew, and it became a real hotbed for research and for innovative stuff during the 1990s. So I was happy to be there. Took on responsibilities for QA, administration, some airway stuff, and produced a paper in that. And then on RSI. And then ultrasound. So Dr. Marks was supportive, but I had to work to get resources and teach and some education. So I took courses for sonographers around the country, and then I went to Australia to do a preceptorship in Adelaide for 6 weeks, and really learned a lot of hands-on ultrasound skills beyond just the learning the content, so to speak, and we have great friends there still. It's sort of sad that I had to go across the pond, so to speak, the western pond to get some training, but that was okay. It was okay. So came back, got on a machine in my department in 1996, and we got going. And that's how a lot of our programs in the United States, out of the necessity to start doing ultrasound for clinical reasons. Our waiting room in the 1980s was full of pregnant patients who had complicated first trimester symptoms such as bleeding, and it was just unacceptable to wait while radiology or an OBGYN had to come get them in line to do an ultrasound. So we had the support of OBGYN and the support of trauma at my department, and that's true, I'm sure, of many departments at that time across the country. Now, I think for your listeners, I think, as you pointed out earlier, Nick, ultrasound was something that now you think is just part of the water. You know, it's accepted. They're pocket-sized machines. They're machines that you can buy for $2,000. You can, there's machines everywhere. But that wasn't the way it was back then. And just to do an ultrasound in your department was actually an act of war sometimes. So we were across the country, there was a lot of frustration by physicians, community and academic physicians. And eventually, Cal Asep, led by Evelyn Cardenas and Diku Mandivia, who went on to be the section chairs of Asep, ultrasound section chairs, got a resolution passed through Cal Asep that went to the Asep Council, which got passed to send to the AMA, saying that hospitals should judge specialties and their use of ultrasound by their specialty specific guidelines and not base our guidelines on what radiology does, and they were requiring just ridiculous requirements and to block the use of ultrasound by clinicians. So that was the AMA House of Delegates Resolution 802, which was approved in 1999, and that set the stage for where I sort of came in. I happened to be a member of the ASEP section in the SAM Ultrasound Interest Group, and Sarah Stamer, another great ultrasound leader, and Evelyn had said it was fine for me to start developing the specialty specific guidelines as a combined effort between SAM and ASEP, and we did. And we produced it in the spring of 2001. Eventually, we got it through the ASEP board in June of 2001. There was controversy in the room from others, but the ASEP board was unanimously supportive. And I will give Mike Carius and the ASEP board and Bob Schaefer-Meyer a lot of credit for really thinking and being brave in the setting of trying to break through the barriers for clinicians at that time. So that was it. Honestly, as soon as the ASEP 2001 guidelines were approved, and it sort of broke the ice and allowed a passage for point-of-care clinicians like emergency physicians to use ultrasound in the hospital. And that, because I think what it did was it said to the world and the medical community, here's what we're going to do. This is our scope of practice. This is our education. This is our credentialing. This is what we're going to do for QA. And then it sort of set the parameters, so people were not worried that we were going to be doing some, weird stuff, which we eventually did do, by the way.
But the old switch,
right? But it's sort of like we were doing it for cardiac arrest. We weren't doing it for looking for a following up a cancer patient after 3 weeks of chemotherapy. That wasn't our goal. Our goal was emergency medicine uses. And so I think that really helped. Eventually, the RRC, SAM, and all the groups in emergency medicine adopted it. We got acceptance by AIUM and the American Society of Echocardiography eventually. And, I think that was a big, big step. I will say that, there were a lot of contributing members, and the ultrasound section of ASAP has been an incredible resource over the last 20 years. I'm happy to have been contributing to it most of the time. And so, we have had a lot of great leaders. Created an ultrasound management course for our members in ASAP who wanted to learn how to run an ultrasound program, and that's been going on annually before ASAP Scientific Assembly annually since 2004. And that led to me writing a book, which I was shocked. I am surprised I ever wrote a book in my life, but I wrote a book with Troy Foster and Mike Blavis called Ultrasound Program Management based on the course. So,
and damn right you should have, Vivek.
Thank you, Nick. Thank you. Then the Asep Guidelines in 2008 came out, and we that really was the guidelines that showed the innovation of Asep. While we called the applications in 2001, they were sort of typical ones. They were trauma, pregnancy, gallbladder, renal, and procedural guidance, and aorta and cardiac. In 2008, we really broke open some innovative uses such as thoracic, ocular, adopted DVT, soft tissue MSK. And I think that showed the disruptive and innovative nature of emergency medicine using ultrasound at the bedside. And now it's sort of a given that we're going to be using a different use almost every day, it seems like. There were threats in the horizon in 2008. There were threats of people not wanting to pay us, and that came from our friends from other specialties. So they were going to ask for accreditation of special imaging such as CT, MRI, nuclear medicine, and then they were trying to include ultrasound, but luckily the ultrasound section in ASAP got that deleted, and that was a great positive thing that happened for our colleagues across the country, that it is a service and that gets paid for in a small way at least. ASAP's ultrasound section created a Sono Guide, which is an online teaching tool, which is now morphed into many online tools on ultrasound. It's gone into the medical school, and people like Dave Bonner, Chris Fox, Tom Cook really were some of the initial leaders on that. I will say, as time went on, the understanding of and the use of ultrasound, it got a little, people would use different phrases to probably try to get it through their systems and all that. And that one term that got used was extension of the physical exam. And I think that while it seems natural, because it's done at the bedside, it became problematic because I think it is a different skill set. It is a different knowledge base. You have to know where to put your ultrasound to get a window. You have to know how to use the machine itself, so even basic machines, and then how to interpret it and apply it. And so we didn't want that as just an extension of the physical exam. And so that was another thing that we've been emphasizing over the last 5-10 years. And ultrasound fellowships have proliferated. There's over 120 now. That's crazy. I mean, it's unbelievable. And ultrasound fellowships really weren't for learning ultrasound. We all want ultrasound to be learned in residency, or if you didn't get it in residency through courses and then doing them in your department. But it really meant for leaders or people who wanted to have that repertoire in their academic portfolio as they were moved on in their life, whether they did international, whether they did military, they were going to do something else, or they wanted to do research, they were going to be the ultrasound director wherever they went. and it is a skill set. So, and it in 2008, I had set up a subcommittee in the section, and that was led by Risa Lewis, and then eventually we voted as a section to pursue certification through ABEM as a subspecialty, and that came through in the last 2 years as a designated focus practice. So that's already through, and then we're now in the next year or two they're going to start having accreditation of fellowships and a test for certification for ultrasound subspecialists such as myself and others. So that's pretty cool, and I've seen the whole development of this field, and I think it's again very satisfying. In 2016, we had new guidelines in Asep for ultrasound and added BAL. TE was also mentioned again, as well as some other advanced uses. And ultrasound, an ultrasound is not just used in hospital emergency departments. It's used in, first of all, other emergency departments, point of care uses now in hospitalist and critical care settings. It's used now in family practice and other specialties. But emergency medicine was the one that broke it open. It's also used in international, military, remote, like space applications, cruise ships. And then, we'll see what happens in the future as well. There are now separate TE guidelines, so that's very exciting as well. The advent of TE, and I'm sure we're going to see a lot of other new applications. I think
absolutely. Could you have ever imagined that it would look like
no,
this?
no. And there's even more exciting stuff. Honestly, Nick, I think you or your generation might be using ultrasound contrast at the bedside, and I'm expecting to see actually therapeutic ultrasound. Like it is possible if you were working in a remote ED that you might be able to use ultrasound to break up clots with the use of contrast or by itself, and save a emergent transport till the next day, whether that's an MI or something else or a stroke. So, that still needs to be developed, but we have a lot of young people who are very smart, and I'm sure they're going to look into the research of that as we move forward. So, there's a lot of exciting stuff in ultrasound. I got to teach around the world and around the country, teaching the emergency ultrasound course with Tom Cook and Pat Hunt, Ken Hines, and I love meeting other doctors of all specialties and teaching others, and it's been really, really satisfying to do that. I love hearing stories from other people. So,
speaking of stories, can you shed some light on what it was like in the quote-unquote days of the Wild West, where back in the early 90s, very few early adopters of ultrasound, kind of kicking the tires on what its uses could be in the emergency department? What sort of things did you see or stories did you hear from those early kind of pioneer days of ultrasound?
Well, I would say to you that, there was always the war stories about trying to get it through your hospital and your department and your hospital or your hospital system, and some of the just ludicrous things that would be said or to prevent us. There were hospitals where the ultrasound machine was chained up, so the emergency physicians could not use it. I'm not kidding. And so, and the other thing, you should know, Nick, is that this is really a sad state of affairs back then. In the 1990s, ultrasound companies were threatened by some other specialties to not market their ultrasound machines to us or any other point of care user, or they wouldn't buy machines. So that was, it was very on the edge of, a legal issue, I would say, or so yeah, that was incredible. I think I think you have to understand what emergency medicine was like if you didn't have ultrasound. So we were doing DPLs and sometimes CTs for abdominal trauma. And I know even from stories from my Denver colleagues, there were people that would get DPLs who were wide awake. So and they weren't shocky because DPL is a very sensitive test, but it just seemed a little bit invasive, if you will. So
right. For our listeners out there, diagnostic peritoneal lavage, Dr. Tayal, since I've done a less than you would find on the number of fingers on one hand, Dr. Tayal is going to tell you about how easy and facile it is to draw fluid from the peritoneal cavity in the acute setting of the trauma patient.
Well, essentially, some patients would have to actually be tied down, so because they were like, "What the heck are you doing?" And then you would numb it up the skin infraumbilically if that's if it wasn't a pregnant patient, and then you would and go down to the fascia and place a catheter in and aspirate and then lavage. And poor Dr. Marks, this was one of the things he researched, so he's probably turning over in his grave right now. But yeah, it was a great test. It's just very overly sensitive. I know your people like in your area in Denver and certainly in Carolinas for cardiac trauma, gunshot wounds, stab wounds to the chest. I mean, we were doing windows, open thoracotomies, if they were hypotensive. It was not. It was like very invasive for the patient, and for pregnant patients who, I mean, as I mentioned, we had we would do choledocentesis or sometimes observation, but there were a lot of things that I think ultrasound sort of revolutionized. I think ultrasound has revolutionized the fact that we don't have to do needle thoracostomy on every patient that we have decreased breath sounds on. So, and there are a lot of other things as well. One thing I wanted to say, Nick, is that during that 2008 to 2020 time, we developed an accreditation for ultrasound accreditation called Clinical Ultrasound Accreditation Program, and I think recent developments or issues that have come up internationally and nationally about the supervision and the structure of point of care ultrasound bring to the forefront the fact that ASAP has its own accreditation program for ultrasound. It's not very expensive, and I encourage all your listeners to have their department go through it. I think it's a badge of honor for some people. It also legitimizes your program, and all you have to do is really have a director, and it doesn't have to be an ultrasound trained person if you're like a fellowship person, but it would be great if it was. But you have to have a credentialing, you have to have a machine, obviously, and you have to have QA and a cleaning protocol. And it tells, I think, the community and the other specialties and the public that you're doing things in a safe manner, and you're doing things according to a national specifications and standards. It's been really cool. I guess everyone knows about the development of ultrasound in terms of the size of machines are down to your iPhones, as you know, and they're going to be even smaller machines. I think they're going to be put on the tip of other scopes and other machines, and we'll see like hybrid type uses of ultrasound. And again, like I said, I'm anticipating therapeutic ultrasound in addition to all the diagnostic and resuscitative ultrasound we do, as well as procedural guidance. So.
It's exciting. I mean, to think of how far it's come in under 3 decades, and to try and project forward the new frontiers is exciting. A lot of the guests we have on here, and we the purpose of this podcast effectively is to interview folks who have just changed the world of emergency medicine. I mean, pioneers like yourself, and some of the most interesting kind of stories and discussions we've had on the podcast have people just have been people reflecting on their time and saying, to think when I started, things looked like this, and now I do them like this. And I would ask if there's anything that comes to mind as you look back, and I know you have a lot more innovation and pioneering to do, but as you look back on your time, I mean, going back into your training, the mid to late 80s, and look back on your career, do you have any kind of reflections in that way?
Yeah, and it goes beyond ultrasound. I mean, by the way, Nick, I did one of my other passions is health policy. I got to be on the North Carolina College of Emergency Physician Board and got to do some stuff there. I will. Yes, I do have some comments on that. I think the integrity of a specialty, especially one that has a very short time to introduction, like emergency medicine for our patients. I mean, we have like within 10 seconds to a half an hour to sort of get to know a patient before we have to actually act. And it's important that the specialty has an integrity. I got to back in the 2000 as president of NSEP, I had to testify in front of the North Carolina Medical Board regarding some other boards that were asking to be recognized, and I defended ABEM and the ABMS on the behalf of North Carolina ASEP. And I thought it's funny. It was just a terrifying experience, but I thought in the end it was actually one of the probably bigger things I've done for our specialty. The other thing I would say is, I think with the volumes that we have seen grow over the last 3 decades since I started practicing, honestly, the amount of acuity and stress and all, it continues to grow. Honestly, I would say the 1980s were sometimes, I think, a little easier. It's a little sad to say, but I find that I feel like the emergency medicine is often asked to carry a lot of the weight of the healthcare system, and whether it's opioids, whether it's domestic violence, whether it's gun violence, whether it's other things like that, injury control, toxicology. We're doing all this stuff, and we do things like ultrasound even, and it reduces time to diagnosis, but we have such volume that it just sort of overwhelms sometimes some of the good things that we do. I think we have a lot of work to do on the healthcare system to try to provide more capacity to people so that they can get the care that they need at a more timely manner and in a more economical manner as well. But I think I was telling your friend Travis and others recently about the fact that I think it's just been a great career. I don't think you'll ever go home and feel like you didn't do something in medicine, and that's something to be said. You have contributed to the welfare of not just your patient, but your department, your community, and your country, and the world. And that happens every day, millions and millions of times a day across this world in emergency medicine. And as President George H. Bush said, there are 1 million centers of light across this country, and those are the emergency departments in this country. I get pretty frustrated when I hear emergency medicine criticized, whether it's out of network balance billing and things like that. Well, some of those things should probably be solved, and we are working to solve things like that. If you had to pay $1,000 for the satisfaction and knowing that you were safe from having an acute emergency, that's what has happened. That needs to happen, and I don't think we should feel sorry about that. I think the services of all the resources that go into providing doctors, nurses, emergency departments is nothing to be ashamed about. The other thing I would say is, especially in this day and age of things like pushing back against vaccines and not believing in other science and not noticing changes in the climate and things like that, is that it is up to us to take the responsibility to represent medical science and represent that on a daily basis to our patients so that they can understand that they're being treated on the basis of not just algorithms and things like that, but actually science. Whether vaccines, how they were developed, how DNA sequencing is going to be affecting them, new molecular treatments for whether it's heart disease or cancer. All those things are so important, but we use those every day. And ultrasound is a great example of that. All of us took physics in high school and college. And then, what's ultrasound? Ultrasound is the application of physics with engineering. You use sound technology and sound physics in application to a human body to learn something about what's going on inside. And it's such a cool thing to look inside the human body. I mean, we usually do our physical exam by examining the outside. But when we are able to do an ultrasound exam, we can look inside the body and know what's going on within seconds or minutes. And that is unbelievable. And it's happened in my lifetime.
It's unfathomable to people who, as you said, who practice even as recently as the 80s, to think that instantaneously and without any discomfort to the patient, you can visualize every major body cavity at the drop of a hat with a device that fits in your hand.
Yeah, absolutely. So, and I will say, I think our residents are quite talented now with ultrasound, and our graduates are. And I know there's stories from across the country. People will come up to me and tell me about, the aortic aneurysm they found or the tamponade, and I know they use it for IV access and central line access and other things like that. So it's pretty cool. And it makes me very satisfied that, it's occurred. I'm sure it'll even get better. And I'm, happy to hear, that things have progressed. So.
And to use your own words, there has to be a better way. And I think that your work with ultrasound is just a microcosm of your career that reflects those words. I mean, we've only scratched the surface on your experience with health policy and your experience with education and disaster preparedness and homeland security. And I think our listeners generally can't listen to a 10-hour podcast, but we could probably fill one with your experience. I do want to ask about, in the same vein of there has to be a better way, with public discourse about, particularly for the 2020 election and health policy discourse. I'm not asking you to solve the United States healthcare system in a podcast, although stay tuned, that could be episode 2 with Dr. Tayal. But for now, I'm just saying, what would be the major important points you would want communicated to an audience about the discourse about changing the American healthcare system as we come into an election year?
Well, I think, Nick, one thing I happened to be up in Washington on Asep sponsored health policy fellowship in 2009 and 2010 in the Emergency Care Coordination Center at in HHS under the Assistant Secretary for Preparedness and Response. So I happened to be there at the beginning of Obamacare and how it was developed. And I will say that I thought Obamacare was a big advance, but it was an advance that I think could have been done a little better, and I am a supporter of it. But I think one thing that I would say is, while a lot of ideas sort of sit there up in Washington and wait for the right time. So that's exactly what happened with Obamacare. We had a president who would be willing to do it. You had a congressional majority. But I think if we had done things a little differently, especially with deductibles and high deductible plans, emergency medicine would not be in the position it is today. And that is, patients, including myself, do not like high deductible plans. And it causes resentment. It makes them question what they're getting, and they don't realize sometimes the efforts that we make on that. So what I would say to you is that, while whether it's Medicare for all or whether it's these other insurance plans, we need to make sure that the plan works for patients on a daily basis or on an affordable basis, so that they're not picking out, they're not going bankrupt for a trip to the emergency department or for their CT scan, for their mammogram or whatever. I think the other thing is, I would say, is you have to know the country. I think, Medicare, the Canadian healthcare system, the English system, the Australian system, they may be fine for those countries, and they have a lot of positive things, but we do need to create a system that works for America, whether you're in the middle of South Dakota or whether you're in Washington, D.C., or Southern California or Denver or Charlotte or Alaska. So how do we do that? It's a pretty tough, ask, but I do think it's something that as we move forward, we need to think about. I would say I'm totally in favor of the fact that insurance administrative costs in insurance companies is just sort of ridiculous, and whatever happens, that needs to be reduced. What will happen with the 2020 election? Well, we'll see. Who gets nominated on the Democratic side, and we know President Trump will be there on the Republican side. So I think healthcare is one of the big drivers for getting young people and older Americans to vote, and I think it'll be a big issue for the 2020 election.
Absolutely, and it's a very high probability that we will be bringing you back to talk about some of those issues as they continue to be brought to the forefront, with your permission.
Of course.
We are so fortunate to have your perspective, and I think we could talk for hours about where you think the field is headed, major challenges that you think the field will face in the next 10 to 15 years, and where you find your next exciting adventures to be. I would just close with that perspective, in that any thoughts about next steps for you personally, and how that relates to where we're going as a field?
I'm not sure. We'll see. For me, I sort of feel like Tom Brady. Won a few, and we'll see what's up for what's the potential.
There's no way that they don't renew your contract.
I don't know if they're going to renew it here, but we'll see what happens. But no, I'm here for the time being, and certainly love contributing to what's going on here at Carolinas and all that. I have a great division, by the way, great ultrasound division, and Tony, Margaret, Denise, Vitaly, Patrick, and Lindsay are fantastic people. So just if I may say that. So it is great to lead a division of such talented people. I just want to say, Nick, I have such respect for emergency physicians across, again, the country, the work they do, whatever hour of the day, and the situations you're put in. It's an honor to be a colleague of yours. So just, my message to them.
Well, we are honored to be colleagues of yours. We look in awe at your career. We look with excitement to your next steps, and we thank you so much for your time. We look forward to having you back on the podcast as soon as possible. Any final points on your side, Dr. Tayal?
I guess I would just say that, my life in emergency medicine was being available for the moment in life when you were asked to do something and it changes your life, So just be available for that time wherever you are, because it'll make you satisfied, and give you fulfilling life.
Well, thank you for being available for us. And in your own words, there has to be a better way for the sake of the patient, and you have dedicated your life to that. And for that, we thank you. And this is Nick Sippis, the host of Unfiltered Podcast with Dr. Vivek Tayal of Carolinas Medical Center. Thank you.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.